It's probably worth emphasizing the change in the DSM in that you can diagnose bipolar disorder if it's associated with medication or ECT. So the distinction has now been lost. We've lost mixed episode and we've replaced it with a mixed feature specifier. And there are other specifiers that are now part of DSM which can be useful. And these are the DSM-5 specifiers. They vary. Some are relevant to manic episodes, some to depressive, and some to the illness course. And these include anxious distress, mixed features, rapid cycling, melancholia, atypical features, psychotic features, catatonia, peripartum, seasonal remission, and current episode severity. Agitation is a particular issue in mania, especially when mixed features are present, and it's manifest as pacing, fidgeting, aggressive behavior, or uncooperativeness. And it can be a medical emergency requiring prompt attention. And a key step in managing agitation is to treat the underlying driving manic episode, but you have to rule out other causes like akathisia. So in terms of agitation, we have divided the treatments into first, second, and third line. I need to emphasize, when you look at first line and you see aripiprazole, lorazepam, loxapine, and olanzapine, they aren't necessarily the first things you would think of. However, guidelines are derived from the evidence base. So clinicians may get used to using agents that work that are not on the evidence base, like other antipsychotics, for example. But guidelines really focus on the agents where there is evidence, and the evidence meets our pre-specified thresholds. So at second line, we have things like asenapine, haloperidol, and combinations with midazolam, promethazine, risperidone, and ziprasidone. So these agents would not surprise you, but we only have 4 first-line agents. The general principles of management of acute mania are to review the general principles and to assess medication status. You need to initiate or optimize therapy and check adherence. You need to add therapies or switch agents, looking at alternative first-line agents. If that doesn't work, you can go to second-line agents and then to third-line agents. So in an acute manic episode, we need to assess the risk of aggressive behavior, violence, and safety to others. Important to index suicide risk, especially in the context of mixed features. Insight is a very important determinant of nature of care required and ability to adhere to treatment. Management of comorbidity is a given, as is the assessment of available psychosocial supports, and routine care obviously would mandate assessment of physical status and a thorough knowledge of current and prior therapies. What needs to be done is antidepressants and stimulants need to be ceased, and sad it has to be said, but frequently this does not occur. And psychoeducation should be given. In principle, you want to begin psychoeducation as early as possible in the illness course. So in theory, you should be commencing all patients on one or more first-line agents using the hierarchical order unless special patient-specific factors override. The evidence base would suggest that combination therapy for acute mania is preferred over monotherapy, but at the cost of more adverse events. And it's important, as far as is possible, to discuss choices with patients and their caregivers. As is the case in all other branches of clinical care, we consider current and prior medication use and response, personal preference. Safety and tolerability is essential to, especially that whatever you treat the acute episode is likely to become maintenance therapy. And you need to look at clinical features that influence prognosis. These are our evidence-based therapies for acute mania. So first-line therapies, in monotherapy, we have lithium, quetiapine, valproate, asenapine, aripiprazole, paliperidol, and risperidone. Cariprazine is a new addition in the guidelines. In terms of combination therapies, the only combination therapies are those for which clinical trials have been done. So they're limited to quetiapine plus lithium or valproate, aripiprazole plus lithium or valproate, risperidone, and asenapine. Olanzapine has been dropped down to a second-line treatment, largely because of safety. Lithium and valproate is a second-line therapy. There's a lot of discussion in terms of the new CANMAT guidelines. So the changes are that olanzapine, ziprasidone, and haloperidol have been downgraded to second-line options. Their evidence of efficacy is offset by safety and tolerability concerns. And that is how the hierarchical system works. So new options, cariprazine, new kid on the block. There are now 3 randomized controlled trials, all of which show a greater rate of response to treatment than placebo. And if you look at the pooled studies, you can see 50% of patients have a greater than 50% improvement in YMRS compared to 36% of patients. No surprise, there are very few antipsychotics that have not shown efficacy in mania.